Hi everybody, this is Professor Butler and this is your information or I should say your content for your pediatric cardiovascular care and conditions. We'll focus on specific conditions related to children as well as specific heart defects. These are your class objectives. They're listed on 2 slides, so here we go. And then please refer to your outline for the chapter and the associated pages for this lesson. Okay, so we're going to start off by talking about, obviously, what do you do for a focus history? Children who have cardiac issues will usually have reported certain things like poor feeding, having some episodes of choking or inability to take a feed in its entirety, or having a long time taking a feed. So poor feeding or a child's unable to take in feeds can cause them to also have weight loss. Children can only go but so long before they tire out. And one thing I want you to remember is that feeding is the exercise for an infant. Feeding is the exercise for an infant. Their responsibility during that early stage of life is to feed, sleep, and grow. All right. So one of the first things we want to ask is, how are they feeding? What are they eating? How long are they eating? Are they having any issues when they're eating? And if so, please describe. Look at a weight. See how they are gaining weight. What was their previous weight? Plot them on a growth chart. Also, because eating involves sucking and swallowing and breathing at the same time, we could also be having some breathing issues. They could have some aspiration issues, so we might have some abnormal breath sounds as well. We also want to see what medications they're on, anything that's associated with their birth history, and usually parents who may not be able to articulate APGAR scores and so forth. We can ask questions. Did they stay in the hospital for an extended period of time? Did they have to take the baby to the NICU? Did they need any type of support after they were born? Those are the questions I usually ask, because it gets to the nitty gritty of, yeah, they had some issues at first and they said they had to take them to this place, and then after about a day, he or she was able to come back. So that tells me that the child had some issues transitioning. And there might have been some respiratory issues. There could have been an issue with their APGAR scores. So it's important that we ask these questions. It's also important to know the maternal history. Did mom develop gestational diabetes? Does the mom have any issues with lupus? Was there any exposure in utero as far as substance use or toxic exposures? It may not necessarily be illegal substances. It could be medications that the mom had to take during pregnancy. So these are good questions to ask, because they could actually help us point towards the possibility that the child could have a cardiovascular issue. Lastly, is family history. Is there a history of SIDS? Children who have SIDS usually might have a cardiac condition that's associated with that wasn't caught, and we'll talk a little bit more about that soon. Anybody in the family that might have a past history of something with their heart. And until you ask like specific questions, it doesn't really cue their mind to remember that, oh yeah, my uncle said that he had a hole in his heart. And that'll tell us that there was a cardiac history. And lastly, one more thing. I'm sorry, I did say lastly before, but recent infections like strep. Strep is associated with a lot of cardiac compromise. So you want to ask if they've had any reoccurring or recent infections. So those are the focus questions that you want to ask when you're dealing with a possible cardiac issue. All right, so let's talk about a focus assessment. We want to look at them. Looking at them will tell us a lot. Looking at their breathing pattern, looking at their color, their tone, how they're behaving, those are all things that can give us a good indication whether or not this child is acting appropriately. So looking at the slide, you can see here overall appearance, LOC means level of consciousness. Seeing if they have pallor, which is just they're just pale in the face, which is an indication of cardiac related issues. Their cap refill is CRF. Looking at their work of breathing, because a lot of times they're also going to have some signs of respiratory distress if they have some cardiac abnormalities. Clubbing. So clubbing usually doesn't happen until after 1 year of age, but children who have a cardiac issue will develop this pretty early on because of their decreased level of oxygen in their body. Vital signs obviously are going to be elevated. Your saturations are usually going to be decreased depending on whatever is going on. Your blood pressures are going to vary. So it just depends what type of cardiac related defect they have, or if there's something cardiac related due to something else. And temperature usually is going to be normal, but there are some cases where the temperature will probably be lower, especially in our infants. The rest that you see here on the slide are their heart tones. We want to know if there's any murmurs. We want to know where their pulses feel like, distally and also proximal. And we want to look at their liver and spleen. You want to look at it on x-ray if you have an x-ray, or you can easily palpate it. And usually these are going to be enlarged if we have a cardiac related issue. I want to talk for a moment about hypertension. Hypertension is something that we're seeing in children, not necessarily because they have a cardiac defect, that can happen, but I also want to talk about hypertension in children in general. Usually this is related due to obesity, poor diet. It could be a family history. So there are certain risk factors that can place a child at risk. We will look at their BMI, we'll look at their weight, we will look at how they're being plotted on a chart for their weight as well as their BMI. Remember, BMI doesn't start charting until age 2. And if they're in the 95% or above in the curve, then we put them at risk. But this one right here that you see is a different type of plotting. This is what they use to kind of diagnose a child with hypertension, and they're either going to be placed into a primary or secondary category if they are at risk. So let me use my cursor here. So here's stage 1. Stage 1 is another word for saying primary. And so if a child falls into, once you take their blood pressure, here's their years of age down here, and then you look at their systolic, which I've been telling you, we really only look at systolic in pediatrics. Nobody believes me until you see all these things. So this is the standard chart that we use, and we will then plot the child. So primary is right here. Obviously, this is where they're getting into the yellow zone, where they're at risk. And then if they're up here in stage 2, then it's secondary. So stages are based on the age and the height and the weight. And once we plot them, obviously we're going to have to do some management, hopefully to prevent them from getting into those zones. But if they are, diet obviously is going to be one of those things. Sodium restriction, potassium, calcium supplements are all things that we will do. We will try not to put children on medications. That's not our goal there, like we would normally do for adolescents and adults. But we want to actually put them in weight management programs, teach them how to eat better, teach the family as a whole. The same kind of approach that we talked about with childhood obesity is the same approach that we will take here. The thing is, if that doesn't work, then we are going to have to put the child on some medications, the same way that we would do for adults, unfortunately. And it's kind of sad because we really didn't talk about this in their earlier years, but now this is really becoming a major problem, and we're seeing a lot of children with hypertension. So murmurs and cyanosis. It's important for you to know what a murmur is. And basically, murmurs are best heard at the apex. And I'll show you in class what I'm talking about, because we can actually mimic a murmur in class. The other thing I want you to know about murmurs is that it can be intermittent, and the intensity or the loudness of the murmur depends on how big the hole is. What we're listening to when we hear that sound is turbulent blood flow going across from the left side to the right side, or the right side to the left side. And that causes that swooshing sound that we hear. If it's really faint, it does sound a little bit like breath sound. So you have to kind of really distinguish between, did they just take a breath, or am I hearing an actual murmur? If it's a really loud murmur, it's very distinct and you can tell, oh yeah, this is a murmur. Cyanosis, however, is something that's unique to infants. And this picture here it shows you the two types of cyanosis that you need to be familiar with. This cyanosis right here is in, as you can see, the blue areas are around the mouth, around the nose. And if we were to open up the child's mouth, you can see probably some discoloration in the mucous membranes. We call that the T area. So it's like here. So it's here and here. So it's like a T. So when we see T cyanosis, that is an indication of true cyanosis, which we call central cyanosis. So that's a cyanosis that's dangerous. These children who present like this, they are truly low in oxygen and cyanotic, and we do need to administer oxygen. Acrocyanosis, which you might have heard in OB as well, is when a child has the bluish color to, as you can see, their feet. Look at that foot right there, and their hands. But you don't really see it here on the trunk, and you don't see it on the face. That's considered acrocyanosis, and that is not true cyanosis. All it is that the child is cold. And so if we would just put some clothes on this child and warm them up, that cyanosis will disappear. Warming this child up here with central cyanosis is not going to make it go away. That child actually needs oxygen. Before we move away from this slide, I want you to understand is that when a child is born, in utero, their saturation is normally at 60%. After they're born, it takes some time for them to reach into the 90s. And it can take up to 15 minutes or so for the infant to transition properly. So when we see blue during birth, a lot of times the first thing that we're going to do is that we're going to give them a little blow by, because we know it's just taking them a little time to transition. Hopefully you've cleared the airway, you've suctioned them, bulb suctioned them, and you don't see any secretions bubbling at the back of their mouth. There isn't any meconium. A part of the delivery process would put them more at risk. But what I'm trying to emphasize is that in utero, they're already in a low saturation environment. So when they're born and the cord is cut, and now the goal is for them to transition and breathe for themselves, it takes them a little bit to rid their lungs of the fluid, and for oxygen and carbon dioxide to exchange, and for their saturations to rise up to the 90s. If we have a child with persistent cyanosis, then we do need to do what we call our pre and post-ductal test. And that will let us know whether or not this child actually has a defect, because persistent cyanosis is one of the things that tells us, I think this child actually might be shunting, for example. We'll say shunting, which is another way of saying we think the child has a heart defect. And using pulse ox is a very non-invasive way for us to figure out if this is the case. So on the next slide, you'll see this test that we do, and it's called a pre and post-ductal test. And so I'm just going to focus on this test right here that we're talking about. So pre-ductal is when you place a pulse ox on the right side. So we would only place it either on the right finger or on the right wrist. And then we would place a postductal either on the feet, or we'll put it on the left hand. So what we're measuring are two different saturations. And usually it has to sit on there for a little bit. We'll put it on there for probably like 5 minutes and then just be monitoring it until we see a consistent number. And if there is a huge difference between your preductal and your postductal saturations, then that tells us that the child is having a shunting event somewhere cardiovascularly. Now, some of the other tests that we would do if we have a positive preductal and postductal saturation test done, we would most likely head directly to an echo, as you see the little baby there getting an echo. We could do EKGs and chest x-rays and CT scans, catheterizations as well. But the main ones that we're going to do is a pre and postductal reading. If we don't know what we're dealing with, real quickly, we can just put a pulse ox on. If it is positive, then we're going to go ahead and jump to an echo and see what the heart looks like. Again, that's very non-invasive. However, the invasive ones are catheterization. Usually with the CT or MRI, we do need IV access, and that's invasive as well. Chest x-rays are good, but they don't give us a really good picture of what's going on in the heart. So here is a picture of an x-ray, for example, and it can tell us the size of the heart. However, this is a very bad x-ray. As you can see, a lot of atelectasis here, and the silhouette of the heart is very enlarged. You have to keep in mind the size of your heart usually is about the size of your fist. And if you can see, this heart is taking up pretty much a large portion of that cavity, thoracic cavity. This is also considered a boot-shaped heart, which we'll talk about later, which is associated with the tetralogy of Fallot. Very, very, very enlarged heart. And with the atelectasis that you see here, you can see that there also is some respiratory involvement. Catheterization, as you know, is invasive, and there are some things that you need to know that are standard procedure for children who do have to get catheterized. Pre-cath care is pretty much routine, the same thing as we do for adults. We have to assist in getting some really good data. If it's an older child, you definitely want to make sure you ask for any allergy to iodine, and see if there's possibility that the child might have some allergic reaction. They do need to be NPO, and they do need to have some good IV access. Post-op care is one that we're going to focus on the most. With post-op care, you want to definitely monitor them very closely. We do have to keep the extremities straight, at least for the good 4 to 8 hours. It's very challenging to do so, especially if there's an infant, but there are some devices that we can use, and we can definitely ask the parents to help us in that with that challenge and holding and making sure they keep the extremities straight. Because when they come out of the cath lab, they're going to have a pressure dressing on there, and the pressure dressing is going to have to stay in place for at least a good 48 hours. We will have to do site care and observe and make sure there is no excessive bleeding. If we do think the child is going to have some bleeding, or if the bleeding occurs and you need to hold pressure at least 1 inch above the site, because that is where the actual insertion took place, and it will stop the bleeding. However, but if you hold just at the site where you think the incision is, that is not going to put pressure on the actual femoral artery. All right, so yes, sorry, I almost forgot one little thing. So glucose levels, because our children have a higher metabolism, we want to make sure that their glucose is monitored very carefully, especially our infants. So we have to monitor glucose levels. Their I's and O's to make sure they don't get dehydrated, site care, we already went over the extremity care. If a child is having surgery from a cardiac standpoint, there are some things that we do have to take into mind. First, we want to make sure that we monitor respiratory as well as cardiac because they're interrelated. They're at risk for pneumothorax, so they usually come out with some type of chest tube. They're also at risk for pleural effusions. Anemia is something that also happens, so we do have to monitor their labs and make sure that their H&Hs are normal. Anything below 13 is usually considered anemic, so we might have to transfuse. They also will have decreased cardiac function, so obviously monitoring is going to be very, very, very important. They can set off arrhythmias, so we have to know how to convert them back to a normal sinus. They're at risk for tamponade as well, and we all know that if tamponade happens, it's an emergency. It's a type of obstruction. It's a cardiac obstruction, and the way to obviously fix that, we can't fix that, but get somebody there who can do a needle chest. The vital signs will be pretty much all over the place. I believe your blood pressure can be high or it can be low depending on what type of reaction the heart is going to take after surgery. But usually your heart rate and your respiratory rate are elevated. Because of the respiratory effects, we also want to make sure that we are also treating any type of distress. So we're going to have to be giving some breathing treatments, making sure that they're positioned correctly, and giving them any type of supportive oxygen as well. Normal thermic temperatures is what we're aiming for. So whether they are responding and getting cold or having increased elevation in their temperature due to possible infection, either way, we have to manage that appropriately with our devices and our medications. And I think that's, oh yes, and so needing sedation for the first few days. So that's important because we want to make sure that they remain calm for lots of reasons. And so if a child gets very upset and they put a lot of stress on their heart, if they continue to do so because we can't get them calm, that actually can set the child back. So we do need to go ahead and take them out of the picture and use sedation just so that the heart has a chance to normalize and the child's normal reaction to a very stressful environment that they're already in, they don't make it worse. So you're going to hear this again. I'm going to go over heart failure, and there's a whole slide on all these different things that we can do to support a child who's in heart failure. So now we're going to focus a lot on the heart. And this slide is just to give you an overview of what you should normally see in a heart. We're talking about the pressures, the saturations, and the normal blood flow. And I just want to take a moment to make sure that we're all on the same page and that we understand what's the normal process. So we're going to start with the pressures. So this is after a child has transitioned, and this is the type of pressures that we should see. So normally on the right side, you should have lower pressures than you have on the left side. The left side has to overcome a lot of resistance to pump systemically out to the rest of the body. So the aorta also has a lot of higher pressures. So ideally, you're going to see lower pressures on the right side as well as your pulmonary artery going to your lungs. And then coming back, you're going to see higher pressures. On your saturations, this makes sense, right? Because coming back from the body is the blood that is deoxygenized. And so you're going to see lower saturations in the right side. And then on the left side, you should have much higher saturations. The normal blood flow, as you can see, is you have the superior and the inferior vena cava going into the right atrium. The right atrium then goes into the right ventricle and then goes up through the pulmonary artery. and then goes to the lungs. There's gas exchange, comes back through the pulmonary veins into the left atrium, to the left ventricle, and then out to the body through the aorta. And that's the normal process of blood flow. So when we talk about these defects coming up, if you need to refer back to this, it's fine, because you'll hear me say higher pressure is now on the right side versus the left side. And this will make sense and why there is shunting occurring, or if there is an obstruction one particular place, you'll understand why now the pressures are lower and why we're having respiratory distress going on versus sometimes edema, versus sometimes higher blood pressures in the upper extremities versus the lower extremities. So we'll walk this through step by step. You have two videos that you need to watch. You have this one on Khan Academy, which I need to make sure that they're still doing it. I didn't check that, but I will make sure that that is available. I don't think that he would take this down. This is one of the top videos that Khan Academy has. So you have the first one, which is fetal blood flow, and this is going to go over lots of different things. It is a phenomenal video. And I want you to focus on the ductus arteriosus as well as the foramen ovale and the ductus venosus. Those are the three ductal lesions, I call them, that are required while a child is dependent on fetal blood flow. And then the next one you'll see is after they're born. So post-birth circulation is the next video, and it talks about what happens both chemically and systematically when a child moves from fetal circulation to newborn circulation, so to speak. Okay, now we're going to talk about congestive heart failure. We're going to define the three types of heart failures. And then we're going to move into some of the acquired conditions, and then I'm going to touch on what we're going to do after that is related to the heart defects. So these are the three types. I know you've reviewed these before, so you still need to make sure that you understand them. And a lot of students, for some reason, have an issue with the myocardial dysfunction. I call it the bad pump. So let's walk through these. All right. So when we have heart failure, we basically look at it from right-sided heart failure, left-sided heart failure, or the heart all in itself is failing. And that's why I call it a bad pump, because you obviously know that the heart is the pump of the body. And when we have a diseased heart, it cannot pump effectively. And so that's why I call it bad pump. All right, back to the right side. So when we have a right-sided failure, we're going to have systematic congestion. So if we think about it, the right side receives blood from the system, right? From other body systems. And so if it is failing, you're going to have a backup at that particular area. So we're going to see the right side not able to pump effectively. And so there's going to be an increase in weight because we're going to have edema. We're going to have peripheral edema. We're going to possibly have ascites. We're going to have distension because the superior and inferior vena cava is backing up, right? So we have that jugular distension. We're also going to have an enlarged liver because it can't pump effectively. The blood is backing up to the liver as well. And so systemically, we're going to be a mess. We're going to be bloated. We're going to have edema, periorbital edema. I will have to say that if a child gets to the point where they have periorbital edema, the edema has been going on for a while and it's pretty bad. When we have pulmonary congestion, or also called left-sided failure, that means the backup is coming from where? The lungs. So this is where you're going to see those respiratory signs. You're going to see tachypnea, dyspnea, retractions. You're going to see feeding intolerance because remember that suck, swallow, breathe mechanism? They're going to have a lot of coughing. They probably have had frequent colds, wheezing, and also grunting. Lots of respiratory issues. If it's really, really bad, then you probably can see back up all the way to the right side as well. But it's due to the fact that left side is failing, and that's why we could see all of these symptoms. Now, bad pump is due to a diseased heart, and that could be due to an infection. It could be due to a damaged muscle. And so the heart in itself, like there's nothing wrong with the chambers, but the heart is diseased. And so the heart is just very weak and it just cannot pump effectively, the heart muscle. Here, what you're going to do, you're going to see tachypnea. You're going to see sweating. The reason why you see tachypnea is because cardiac output is dependent on what? Stroke volume and heart rate. And so it can't increase the stroke volume. So what it's going to do, it's going to say, okay, well, I'll just pump faster. I'll just pump faster to meet metabolic needs. And so the cardiac output is decreased. And so the heart says, okay, well, I'm going to beat faster. So that's why they get tachypnea. This is also why you see sweating. So when we are exercising, our heart pumps faster. And so what we do is we sweat, right? Because we're exercising. Again, when the child is tachypnic or tachycardic, they're going to start to sweat. And so you'll see a child just laying there in the bed and they're sweating and they're not doing any activities whatsoever. They're just sweating. So that's a clear sign that the child is so-called laying there in the bed and they're exercising, and we see that because they're sweating. Low urine output. So because we don't have good cardiac output, the kidneys take a hit and then they're not able to filter urine properly. And so you're going to see a decrease in urine output. They're going to get very lethargic. They're going to be very pale. They're going to have very weak pulses in their lower extremities. Their blood pressure is going to be very poor. And they also are going to have a lot of weight loss. So notice here, you see a lot of weight loss. But in here, we have an increased weight loss. So make sure you understand the different signs and symptoms of heart failure. And now we're going to get to the point where we're going to talk about how do we treat these things. Some of these things, again, are going to be a review, but we're going to talk about some specific things related to pediatrics. So first off, medication. One thing I want you to understand that oxygen is a drug. We have to be very careful how we use oxygen in children, specifically when we're dealing with a heart defect. Oxygen can either help or hurt in the situation, depending on the defect. And so when we talk more about them and go through them, it'll make sense. But the medication listed below that, prostaglandins, is one of the main reasons. You cannot have delivering a whole bunch of oxygen while you're delivering prostaglandins. They work against each other. So with prostaglandins, this is a chemical that's normally released that keeps the ductal lesions, the ductus venosus, ductus arteriosus, and the foramen ovale. It keeps them open in utero, and then when they're born, it drops. And so then we have a slow closure of these lesions. And when we have a ductal dependent defect, then we need to administer prostaglandins in order to keep them open so that they can survive. When you are dealing with a ductal dependent defect, you need to make sure that you have 2 IV accesses. The half-life is in a matter of seconds for this medication. So that means if you lose your IV and you don't have a backup, and we have a very difficult time getting an access for this child, they could possibly die. Because the minute that it stops infusing, this continuous infusion, then they will, the ductal lesions, or I keep saying ductal lesions, the ductus will end up closing, and that could end the life of that child. So again, prostaglandins are a continuous infusion that we use to keep the ductal dependent defect lesions open. If a child requires this, you have to have 2 IVs in place. I'm going to talk about the exit procedure. This is something that we do when we have specific defects, where we would deliver the hand before the baby, and so that we can put in an IV. That is how important an IV access is when you are administering prostaglandins. All right. Indomethacin, which is also called Indocin. Indocin is a medication that helps to close certain ductus, specifically ductus arteriosus. So that's a medication that we use specifically to close ductus arteriosus. Digoxin, you guys know digoxin. Digoxin, you have to be careful with digoxin, and specifically you have to be careful when a child is receiving diuretics, because it can increase the effect of dig and make them go into dig toxicity. All right, calcium channel blockers. Very rarely do we use calcium with children. We do use it in emergencies if we realize that the child is having some issues with calcium. That's our cause. Diuretics are commonly used. We will use Lasix for like periodic needs to decrease edema, but long-term use for Lasix, we usually use Diureal or aldactone. Beta blockers are used obviously to decrease heart rate because it's putting too much stress from a respiratory standpoint. It also reduces preload and afterload. But you also need to make sure with beta blockers that you understand your parameters. It causes vasodilation, it decreases the heart rate, and we are to hold it if they have a specific heart rate or blood pressure measured before giving that medication. The main one that we give with that one, we use Inderal or Corig. Let's see, ACE inhibitors. We do use ACE inhibitors. They reduce the afterload. Big ones that we use are Vasotac and lisinopril, especially in the African American population. Lisinopril is very popular. As you remember, these medications help relax the veins and the arteries, and they help to lower blood pressure. When you have that happening and you're decreasing blood pressure, you're probably also decreasing cardiac output. That means you need to be very careful on the output and the kidney function specifically. When I say output, I'm talking about urinary output and the kidney function, to make sure that we're also not affecting that. I used to, just FYI, I used to have Viagra on here because it's a great pulmonary vasodilator. But we ran into some issues with Viagra with children, and they actually took it away. So we used to administer Viagra to children. It did also have the same effect as why people use it on the market. But kids don't really care about erections. But it was helping them from a cardiac standpoint. But they took it off the market for children. Let's see. So now we're going to talk about dig in particularly. I already told you one of the precautions. You know, you must take your apical heart rate. And I emphasize apical because you don't want to always just go off of what you see on the monitor, because the monitor can have artifacts. We're going to use the parameters that you see right here, 90 to 100 for infants and 70 for older children, just for the sake of testing purposes. But obviously when you are in practice, you need to make sure that is a part of your orders. This has a very narrow therapeutic window, so you do not redose. And this is important in pediatrics because children do not sometimes spit out their medicine. And I've actually had that happen to me. And when the child spit out their medicine, they didn't get redosed. And so we don't know how much of the dig that they actually received, but we also don't want to overdose them either. Some of the side effects are listed there: nausea and vomiting, obviously bradycardia, dysrhythmias, and then our normal maintenance dose is 10 to 15 micrograms per kilogram per day. It's divided into 2 doses, and the doses are usually less than 1 ml orally, and then IV doses are between, as you can see listed there, 0.62 and 1.25 milligrams in children. And that is a standard. So if somebody was to bring me a syringe that had, let's say, 1.5 for an oral dose, I would know that they have miscalculated. Something's off, and I wouldn't co-sign that ditch with them. So make sure you know the standard dosing for DIG. We also need to monitor potassium when we're giving diuretics as well, because it has a reverse relationship. Increasing potassium decreases DIG effects, and decreasing potassium levels increases DIG effects. So go back and read about DIG if you don't remember that one, because you might see that pop up later on. When we're giving ACE inhibitors, we also need to monitor renal function, which I already told you about that because of the decrease in cardiac output, and signs of DIG toxicity are listed there. AV block is very uncommon in children, but it can happen, especially if they're on DIG therapy. Lethargy and electrolyte imbalance, as we mentioned specifically, and then renal failure. So here's a slide that I was talking about before. I was talking about the things that we do as a nurse to help manage heart failure. So I'm going to take it from the top here. So the first one we have listed is decreased cardiac demands. How we do that is make sure that we maintain normal thermic conditions. We want to make sure we stay on top of any signs of any infections. We want to put them in a semi-Fowler position, which is the head of the bed up at 45 degrees. Sedate if necessary. We talked about that earlier. And make sure they're in an environment with decreased stimuli. If you have a person who wants to constantly hold them or touch them, or a parent who's just really anxious and they keep messing with the child, that actually stimulates them, and it actually increases their cardiac demands instead of decreasing. So it's good to have some wake time so they can have bonding and all the things that they need from a growth and development standpoint. But this child is going to need added rest and sleep, more than what a normal child would need. So it's really important to promote rest for these children. Improved cardiac function is our next one. Here we're going to administer any of those medications that are indicated if necessary. And then we're going to reduce respiratory distress. So respiratory distress will put more demands and more stress on the heart. So the way that we reduce that is to make sure that we monitor for signs for respiratory distress, give oxygen if needed, maintain normal worker breathing. That means giving respiratory bronchodilators. We might have to give, we might have to do treatments, bronchodilators, but what I'm thinking about treatment is we may have to help them with airway clearance, is what I'm struggling to say here. We may have to, the semi-Fowler position that we talked about before is definitely important. We may have to put them on reverse precautions. In the NICU, it's kind of already set up like that, where people have to scrub before they come in and wear gowns. And then anything, wear a mask around them as well. Anything to enhance good respiratory flow. Maintain nutrition. So again, these children are going to need a high caloric intake because they have higher demands. Their poor body is working really hard to maintain metabolic needs. So we may have to increase their calorie formula. We may have to increase their concentration in their formula by adding things to it. The normal concentration for breast milk and normal formula is 20 per kilo, 20 calories per kilo to be specific. And then we may have to put stuff in there to basically fatten them up, to meet their caloric needs, in other words. So we may have to enhance it to up to 22 calories per ounce, or 24 calories per ounce, or I've seen all the way up to like 30 calories per ounce. And so here you see, on average, they need 120 calories per kilo over the entire day. And so nutrition will obviously do all these calculations for nursing and make sure their calories per ounce are appropriate so that they can meet their caloric intakes. I also want to mention that with these children, because they also tire out so easily, The way that we would make sure that they get their nutrition is to have limits and time limits on the amount of time we allow them to feed. Remember, I said feeding is the exercise of an infant. So when they are feeding, usually we say we don't let them feed any more than 20. Some places might let them go 30 minutes. After that, they're done. So if a child was supposed to take 60 mLs every 4 hours of 24 calorie infant care, so to speak, if that child gets to 20 minutes and they're, I can't even get them to even take really good sucks, and they've only taken 40, then I'm going to put the rest of the 20 mLs through an NG tube. So we need to make sure that these children already have an existing NG tube in place. They have to have another means of getting nutrition in them, because obviously we're not going to put down an NG tube after we feed them. That's going to make them throw up. So we always have to have some type of device in place so that we can feed them the rest if they don't take it. If they do take it, great. But if they don't, then we need to have a method to get it to them. So that's something that nurses always have to keep in mind with these children. Promote fluid loss. So obviously we're going to give diuretics. We're going to limit the amount of fluids if necessary, and then alter their diet. So limit fluids. Limit fluids kind of is what we just talked about before. So sometimes we will increase the calories in a formula or breast milk so that they don't have to take as much fluid. So let's go back to the example I said. I said 60 mLs every 4 hours of 24 calorie infant care. Let's just say that ends up being too much fluid for that child. And the doctor wants us to reduce fluid intake, and we have to reduce now that 60 mLs of 24 calorie infant care down to 40 mLs. Okay. So the nutritionist will then increase the calories so that we can meet caloric needs, and that will also decrease the amount of fluid that we have to give the child. And therefore, we're meeting both as long as the child can tolerate a higher calorie. Therefore, we actually are promoting fluid loss or preventing fluid gain. So that is one way how we use this to manage this. And then last, we have support family and educate. This is a no-brainer. We have to use family-centered care, where we reduce the anxiety of the parents. We use anticipatory guidance of what's going to happen. Okay, so today your child's going to have a cardiac cath. Any questions, make sure you give them information, figure out what's the best way for them to take all this information in, and then definitely follow up with them and saying, hey, do you have any questions? Is there anything that you need to know before tomorrow? Because a lot of these children are going to go through stage procedures, and it's a long journey. And it doesn't stop after the surgery. They're going to need some type of long-term care, cardiac-wise, for the rest of their life. And so this is something where we can really support these families in a way that will help them get through this very, very challenging time. And using anticipatory guidance, always following up and addressing their concerns, family-centered care, and making sure that they are a part of the team. So acquired conditions. So we just have actually two, I believe, that I'm going to talk about, and that's rheumatic fever, also known as scarlet fever. This is associated with group A strep. It is an immune response to group A strep. It affects the mitral valve, and some of the things that we see mostly are joint pain. We'll see a rash, as you can see this, I call it the strep rash. But it's a macular papular rash. So it isn't usually raised, it's usually very flat. Treatment obviously is antibiotics because it is associated with an bacteria. It is, reoccurrence is high. They usually have to have some antibiotics before they have any dental care, and they could have to have a mitral valve repair as well. But usually the classic signs that we see are, one, they have a history of having group A strep. They usually can have this rash, but not always. Not always. They will have a positive anti-strep titer. We'll see usually some heart effects on it on echo, and you'll definitely complain about joint pain. And they will, I'm not sure about the twitching and the jerking, the muscle weaknesses, but they definitely will have issues with their joints. So make sure you read up on that one. This one is a biggie, Kawasaki's disease. So Kawasaki's disease is something that we see quite frequently. It does show up usually in childhood. It usually is seen in populations of Asian descent. This is a system-wide vasculitis of the veins and the arteries. This can lead to damaged arteries, as well as a child can have a stroke. They can have a coronary arrest, and it can be pretty painful for them initially. With these children, they present very classic, and let's see here. How do I want to start with this? So let's go through the stages. I think that'll make sense. So there are 3 stages as you see here. We have acute, subacute, and convalescent stage. Your book does not really do a good job of explaining the phases, so I'm going to walk through them this way. Remember, we're dealing with a system-wide vasculitis that deals with both the medium and the small veins, even some capillaries. All right, so the acute phase is a part of the illness when symptoms will appear and they are at their worst. Patients usually have joint pain. They could be having nausea, vomiting, and diarrhea. This phase usually lasts about 2 weeks. And what we hear from the parents is that they're having very, very, very high fever. They're very irritable. They're not eating. It's just a horrible time. They've tried everything that they could possibly do. And then they start to see things like dry, cracked lips. They'll have a strawberry tongue. They'll have conjunctivitis, a lot of tearing. Here's the this stands for irritability. And then a lot of swelling and redness of their feet and their hands. They'll bring them in. And we're usually diagnosing this due to history and as well as symptoms. There isn't really a diagnosis, a lab test that says that they have Kawasaki's disease. It's more of us painting a picture and saying this is Kawasaki's disease, and then seeing how they react to treatment. So the first treatment that we're going to do is IVIG. They will receive IVIG to stop this massive inflammation. And they'll usually get it over a whole day. So IVIG, I don't know if you've done IVIG, is a very staged infusion. But remember, it is also a blood product. Then we're going to go to the subacute phase. And during this phase is when we still have the fever, but the fever is resolving. They'll still have a rash. They may see some lymph node swelling, may go away, but the other symptoms will remain. So here's the lymph node right here that they usually had, and this will go away. And then the third stage, which is convalescent stage, this is the stage where all of the symptoms have resolved. So when we get to the subacute phase after they've received IVIG, they're going to get aspirin therapy. We'll start with a high dose, and then we go to a lower dose. And they will actually be placed on a lower dose continuously even when they go home. They will be followed up with cardio on a regular basis to make sure that they don't have any vessel damage, to monitor to see if they have any signs of possible stroke. And before they go, we will also look and see whether or not they have any rupture of any arteries, any aneurysms, anything like that could have occurred during this whole treatment phase. Sometimes they'll do Lovenox, especially if a child has been identified having a clot while we were treating the child and monitoring their veins. And so if that is the case, or if they had a stroke in general, then they will be placed on Lovenox instead of aspirin. But because we don't want to put children on Lovenox, we will start off, our main thing is to give them aspirin. All right, so let me go back and kind of recap this. We know that Kawasaki's disease is a system-wide vasculitis. They're at risk for coronary events, including stroke. It can lead to damaged arteries. These are the symptoms classic symptoms that you see here. You have conjunctivitis. They'll have irritability. They'll also be very dehydrated, but they'll be dehydrated due to the fact that of all the high fevers. Excuse me. They will have that strawberry tongue. They'll have enlarged lymph nodes, as well as rashes on their hands and their feet, as well as some swelling and irritability. So these are the classic signs that we see. Treatment is based on their symptoms and their history. We'll start off by giving them IVIG. And then once things start resolving, we'll place them on aspirin therapy. They'll stay on aspirin therapy for the long term, and they'll be followed by cardiology. If a child has developed a clot or had some type of cardiac event associated with Kawasaki's disease, they will be placed on Lovenox long term. There are 3 phases. We have the acute, the subacute, and the convalescent. They are not listed in your book, but you do, I've told you them here. And I think that's it for Kawasaki's disease. Very interesting condition to treat. All right, so now we're going to talk about some pediatric heart defects. I'm just going to briefly describe them, because in class, we're going to have an activity associated with them. So you have 4 that we're going to deal with. We have acyanotic, cyanotic, mixed, and obstructive. Acyanotic deals with an increased pulmonary blood flow through the pulmonary artery. And that is usually due to some type of shunting from the left side to the right side that increases the amount of flow going through that pulmonary artery, or it could be something else. So therefore, we have a flooding of the lungs, and we're going to have some issues on the right side. Also on the left side, because we have shunting, we're going to have a decreased cardiac output. Cyanotic is a decreased pulmonary blood flow. So that means there is a decreased amount of blood flow going through the pulmonary artery, and it could be shunting over to the left side, or there could be obstruction. I'm not sure. But regardless, there is a decreased pulmonary blood flow. So if we don't have blood getting to the lungs, you know what's happening, right? We have a blue kid. Blood is not getting to the lungs. Therefore, they are cyanotic because they're not getting any of the blood needed to be oxygenated to the left side to go out to the rest of the body. So that's why it's called cyanotic. Mixed means we have a mixture of both acyanotic or cyanotic issues going on, and therefore there's some mixing of oxygenated blood versus deoxygenated blood. And so usually in these images that you'll see later on, you're going to see purple. And purple tells you that there is mixing of blue and red. Then we have obstructive heart defects, and these are due to some type of obstruction somewhere in the circulatory flow or system that is due to usually atresia versus a stenosis. So atresia means there is a complete closure, and stenosis means that there is a narrowing. Either way, whether it's narrowed or whether it's completely closed, it's obstructed in some way. So the goal, obviously, in this type of heart defects is to fix that obstruction. But we also need to understand where the obstruction is and what we should expect to see going on in the child. So I will explain to you what we're going to do in class for this activity. You need to make sure that you come prepared to talk about your heart defect.